Welcome and thank you for joining us online for this very first Flinders University Meet the Minds, titled Neglected Minds, Challenges and Strategies for Promoting Mental Health in Aged Care Users. I'm Chantel Crossman, Manager of Partnerships and Events in the Office of Communication, Marketing and Engagement, and I'm excited to host today's inaugural Meet the Minds event, which will explore the complex causes of psychological ill-being and illness in aged care environments. To begin with, I'd like to acknowledge that we're hosting this virtual forum on the traditional lands of the Kaurna people, and that we pay our respect to their elders, past, present and emerging. We also acknowledge and convey our deep appreciation to the elders of all nations upon which Flinders operates. As mentioned, this event is part of our new Meet the Minds lunchtime lecture series. This is an opportunity for you to meet some of Flinders University's most engaging minds as they bring you their latest research from a diverse range of fields. This snapshot lecture series will occur every fortnight and only run for 30 minutes, providing you insight into topics that are challenging and changing the world around us. Today, we are fortunate to be hearing from Dr. Monica Cations. Monica is a provisional psychologist and epidemiologist who has worked in the ageing and dementia field for over a decade. Her research focuses on psychological wellbeing in aged care environments within the College of Education, Psychology and Social Work, supported by overlapping fellowships funded by the Hospital Research Foundation and the Medical Research Future Fund. We're keen to make this an interactive event via a live Q&A forum within the Teams platform. This is your chance to participate in the discussion and to pose questions to the speakers in real time. Finally, as Meet the Minds is delivered entirely online, if you have any technical issues, please email the events team via events@flinders.edu.au, who are on standby to provide support. And so now it is my pleasure to invite Monica to commence her presentation. Thank you, Monica.
Thanks so much for the introduction and for having me today. I'm really thrilled to be speaking, particularly for the inaugural event of Meet the Minds. It's a real thrill to be here. I'm going to be talking today about the quality and safety of aged care, and in particular psychological wellbeing within aged care environments, which forms a big part of the research that I'm doing with my fellowships. So as you would all probably know, the quality and safety of aged care in Australia has been repeatedly condemned. You would all be aware that we've recently completed a Royal Commission into aged care quality and safety. And ultimately that final report described what is quite a medicalised industry, a risk-averse culture, with a real over-reliance on what's called chemical restraint. So particularly in residential aged care, this overuse of sedating medications to manage the residents and the work there. What those of us know who have worked in this industry for a long time is that these problems have recurred over a very long time. The Royal Commission is the 18th government inquiry into the aged care sector in the last 20 years. So these problems are not new, and certainly the findings of the Royal Commission are nothing that we haven't known for a long time. And also these problems exist internationally and occur all over the world. So in terms of mental wellbeing late in life, we know that mental wellbeing typically follows a U-curve over the lifespan. So usually we are at our happiest late in life. But what we also know is that psychological illness is underdetected and undertreated in older adults. So there's lots of reasons for this. Partly it is because there has been a cultural shift over time where it has become more acceptable to speak about our mental well-being, which wasn't so much of the culture back when our older people who are alive today were younger, but also because health professionals don't have the skills to identify and treat psychological illness in this population. We also know that older men aged over 85 years have the highest age-specific suicide rate in Australia, particularly men who live in rural and remote areas and maybe have more access to firearms in those areas. And of course, also loneliness is very common among older people. At least 46% of older people report feeling lonely at least some of the time. And so among people living in the community, so not living in residential aged care, around about 13% of older people live with depression, and that rises to about 25% among people living with dementia. And 3% have one or more anxiety disorders, and that again rises to 14% among people living with dementia. In residential aged care environments where people are living in institutionalised settings, at least 62% or more than 62% of people are living with at least one psychological disorder, most often again depression, anxiety, or some kind of psychotic illness. That all of these things can be also complicated by a dementia or another illness. So in terms of the current service landscape for older people and their mental wellbeing, I think that the final report of the Royal Commission into Aged Care, Quality and Safety really sums it up, that they have said, and quite plainly, that older people with mental health issues are often heavily medicated but do not receive access to preventative care and other treatments. And so that has certainly been my experience in this industry. There is the Older Persons Mental Health Service, which is a government funded service, which I'm not an expert about this service, but my understanding is that their remit is mostly for people with quite severe psychological illness. Older people living in the community with less severe mental illness can access the same mental health supports that the rest of us can through community psychologists and other services. But people living in residential aged care were not eligible for Medicare rebates for those services until very, very recently. And even now, getting access to psychological support and other services if you live in residential aged care is very, very difficult. So what gets in the way? Well, one big barrier to better meeting the psychological needs of older people who are accessing aged care services is that, particularly in residential aged care, these are highly medicalised environments. They're environments that are led by doctors and nurses, often have care staff who have a kind of minimal level of education or don't have the level of clinical skill that is required to support mental health needs. And so there's a lack of funding or accreditation standards dedicated to allied health services. So it's relatively rare to see a psychologist, a social worker, sometimes even an occupational therapist in particularly residential aged care environments. And there's just not this culture of allied health involvement, and that was something that was touched on extensively in the Royal Commission. On the other side of that, there's also a lack of skilled professionals. So I'll talk a little bit in a moment about the fact that there are very few psychologists who have interest and expertise in working with older people. And in general, there's just a low level of workforce psychological literacy. So the ability of the staff who work in aged care to recognise when an older person has psychological needs that are not being met, and then to know what to do about that and where to refer that person to. There's a really low level of kind of knowledge and competence in that area. And then of course there's all the other problems that contribute to poor care, things like privatisation, low quality standards, and a lack of transparency. So as I mentioned, there's really not enough workforce to combat this problem. So the Australian Psychological Society, they provided a submission to the Royal Commission that made the note that only 6% of psychologists in Australia specialise in treating older adults, and the extent to which psychological approaches can be employed in residential aged care is limited because we don't have enough psychologists to do the work and enough psychologists who are passionate about that work. And the problem is cyclical in that the funding isn't provided to promote the provision of allied health services, counselling, social work, psychology in these environments, which means that there's no incentive for professionals to become specialised in those areas. And so the problem goes around and around. So certainly from my experience, as Chantal mentioned, I've been working in this industry for a while now. And my experience really has been that the quality of aged care varies very widely. Most of my experience has been in residential aged care environments where opportunities for life enrichment are sometimes seen as sort of optional extras. You know, we keep the person alive, we keep them fed, and we keep them from falling over, but if we keep them happy, well, they have to pay more for that, or that's kind of an optional added benefit that we may provide or we may not. There's really few opportunities for allied health clinicians, particularly mental health clinicians. There's not a lot of well-paying, good career paths for psychologists to become involved in the aged care sector, or social workers, or counsellors, or any other kind of mental health professional. There has been progress in my time in this industry, but it is too slow. And really, we appear to be lacking this community push to improve standards. Our standards for what we expect our older community to receive are too low, and that has very complex causes, including ageism, including a sense of nihilism. Well, you know, they're old anyway. And I think a sense that it's just too complex a problem, and I myself am, you know, fall victim to that sometimes, feeling that this is too wicked a problem to solve, but it's not. All it takes is some will. And I think if we all ask ourselves, you know, we must consider that this is not an us and them sort of problem. We all will face this as we get older, and we should ask ourselves, should I be privileged to grow old? What would I expect for myself? What would my standards for myself be, and for the people who I love? So in terms of my research and some of the work my research team has been doing, one of the key knowledge gaps that we identified was that there's actually no evidence out there to inform the government about the barriers to accessing mental health service use for older people, and also the potential benefits of these services when they're actually used. And so without having that knowledge, there's really no imperative for the government to invest in services and invest in implementation. And so the Registry of Senior Australians, which is a large data registry that is hosted at SAMRI, is a really helpful tool for this problem. It includes data about aged care, health service and pharmaceutical services use for all older Australians who've accessed aged care since 1997. So it's a really powerful data resource that tells us about what kinds of services are people using and what are the long-term impacts of those services. And so what we're planning to do over the course of my fellowship in the next few years is to find out who gets access to government subsidised mental health services if they live in aged care, what kinds of people are actually getting the access and who's not. How are those services then used? Are they effective, and are the benefits equitable across all of the people who need them? So that will be a very important piece of work that was noted in the Royal Commission to be really missing in the data landscape. In terms of meeting psychological needs on the ground, there's a fairly robust evidence base now that the efficacy of psychological therapies for anxiety and depression in older people, including people living with dementia. Typical or kind of traditional therapies like cognitive behavioural therapy are well established. But the bigger question is, how do we improve access to these services? And also, how do we improve uptake? Uptake is a big problem, particularly for our current generation of older people and the generations before them, who may not recognise that they require support, or may not feel that psychological services will be helpful for them. And so there's a lot of research happening in that space, which I'm not involved in, but is certainly happening all over the country to improve access. The Better Access Scheme, which provides subsidised psychological services for people with mental health problems, the eligibility for that has been extended to people in residential aged care, and hopefully we'll see uptake of that improving in the next few years. The use of telehealth is becoming more common, and there has been a redesign of the older person's mental health services since the Oakden report, which you all may be familiar with. But to talk more specifically about my research, I'm particularly interested in the impact of psychological trauma in late life, because this is far less talked about than depression, anxiety and other sorts of conditions. But more than 70% of older people have experienced a psychologically traumatic event, and we know that that can affect the experience of receiving care services in important ways. And so common reactions to re-traumatisation include things like anger, hoarding, even withdrawal, silence, which if you've worked in aged care, if you've ever worked with people with dementia, you would recognise some of these things as sometimes being called behavioural symptoms of dementia, when it would make sense that these are actually natural reactions to being triggered. I'm just going to skip through this so I don't waste too much time. So we're quite interested in the potential utility of trauma-informed care in these environments. So trauma-informed care is a model of care that's used a lot in mental health care services, homelessness services and elsewhere, that recognises the central role of psychological trauma in shaping our experiences. And so the idea is not that everybody in that system can treat psychological trauma, but that everybody has the ability to recognise when there are trauma-related needs and knows what to do about that and who to talk to about that. And so in that context, safe care for trauma survivors is both person-centred and trauma-informed. And just to note that the Aged Care Royal Commission did make a recommendation that all aged care providers should be able to deliver trauma-informed care, but actually, which is good, but actually there's not yet any evidence telling us whether trauma-informed care actually is an effective model of care in aged care environments. And so that is the question that we're seeking to answer in some of our research trials at the moment. So we want to know, can implementing trauma-informed care improve the quality and safety of care in aged care? And can that also reduce the number of challenging behaviour events or incidents and the use of chemical restraints? So we're currently undertaking 2 separate trials of trauma-informed care, one in geriatric hospital wards within the Southern Adelaide Local Health Network, and one in residential aged care environments. And the idea is that we're working together to go through a co-design process to decide, right, what does trauma-informed care look like in practice? What are the behaviours that we are going to carry out that would make us a trauma-informed setting? And then we're going ahead and implementing that in each of those settings. And so we hope to learn from this that what kinds of changes these environments are willing to make, how much wiggle room is there to improve the psychological literacy of the staff who work in these environments, to what extent do they make those changes, and what effects do those changes have when they're made. So rather than investing more money into providing people with psychological expertise into, kind of parachuting into aged care environments, what if we work to improve the psychological literacy of the people who already work there and build on their existing skills? What kind of impact does that have? I'm just going to skip over that too. Just finally, a comment on kind of where to from here and beyond the Royal Commission. It's likely that funding will increase following the Royal Commission, which is good. Regulation is likely to tighten, which will be difficult, I think, for aged care providers who are weary and have endured years and years of regulation change, repeated regulation change. But what I really hope to see is that we're going to have increased transparency and higher standards. I'd really like to see us lift our standards as a community about what we expect for our older people. I really hope we see more investment in allied health and more work to consider the diversity of the population of people that we're working with. And an investment in workforce wellbeing, because the aged care workforce have really tough job, and the worse they feel, the worse the care is that they're able to provide. So I think that I would like to see quite a lot of investment in workforce wellbeing as well. So I'm going to leave it there, but thank you all so much for the opportunity to tell you a bit about mental wellbeing in aged care.
Thanks, Monica. I'm getting feedback, that's all. I am going to kick off the discussion. So you did touch on the response to the Royal Commission there, Monica. So I'm going to kick off with a question. Why are mental disorders under-identified and under-treated among older people?
Look, there's lots of different reasons for that. Like I said earlier, older people, there is less willingness among our older adults. There's been cultural change about talking about our mental well-being. Mental illness, psychological illness, also looks different in older people to how it may look in younger people. It may present in different ways, so it can be hard to pick up. And also there have been cultural shifts in the way that we perceive treatments for psychological illness, that things like therapy have become far more accepted treatments over time. And so there are these kind of cultural barriers, I guess you would say, to picking up and treating older people with psychological illness.
Thanks. Gareth has left a question for us on the Q&A functionality in Teams. He would like to, what would be some example of what we would see differently in aged care settings where trauma-informed care has been implemented?
That's a really good question. So some of the work that we've done so far has helped us understand what aged care providers might be willing to do and might be willing to change. And I think the first thing is this fundamental understanding that life experiences, traumatic life experiences, can impact the way that we communicate and the way that we behave. I think that at the moment we really pathologize some of these behaviors, that they're just a symptom of the dementia, or that they're kind of easily explained, but we don't do enough to kind of look back in this person's history and put the pieces together to understand why Mr. Smith is really distressed by the bright light in his ceiling, or whatever it is. And so I think that would be a huge change, that even recognizing that psychological needs impact our behaviour and well-being, and that this person comes to aged care with this lifetime of experiences behind them, that would be a big change in an aged care environment.
Thanks. Thanks, Monica. We've got another question from an anonymous viewer. What role can families play in supporting loved ones who have mental health issues in aged care?
That's another good question. I think at the moment there's this sort of piecemeal access to mental health services, particularly for people who live in residential aged care. And so I think if your family member lives in residential aged care, sometimes the best thing you can do is to be their advocate and help the staff who work there to recognise that there are psychological needs that need to be addressed. And sometimes we even need to let the facilities know what services are available out there. There are now great telehealth counselling services available that older people who live in resi care can access. And so getting upskilled and getting educated about what's available, sometimes family carers have to be the ones to come in and let the facility know, which is not ideal, but is the reality at the moment.
And another anonymous one, what do we know about the most common traumatic events reported by older people?
That's another good question. So we are having the Vietnam veterans are now reaching later life. So the World War II veterans are slowly kind of dying out, but the Vietnam veterans are now coming into older age. So there is a cohort of people who've experienced conflict-related trauma, but we also know that there's a huge population of people who have experienced childhood abuse. There's a very large population of people who were placed in institutional care when they were children, before institutional care sort of went out of vogue in the late 1900s. And so these children, as you may know from the Royal Commission into Institutional Childhood Sexual Abuse, many of these children experienced abuse in those environments. Many of them experienced dislocation from their families, forced labour, all sorts of really terrible experiences. And a large group of those people are now reaching older age and because of their experiences are ageing quickly. And so that group, care leavers, the Forgotten Australians, stolen generations, that makes up a big bulk of older people now who have experienced psychologically traumatic events.
Thanks, Monica. Malcolm has asked, does CBT work for older people, particularly with anxiety and depression and dementia, and what adjustments have to be made, and can it be delivered by telehealth?
Yeah, so CBT absolutely is an effective treatment for anxiety and depression among older people and for people living with dementia. And yes, it can be delivered by telehealth. There are more and more services delivering telehealth services for older people. And you know, older people now, and this will continue into the future, are increasingly tech savvy and willing to engage in telehealth. Certainly when you're working with a person with dementia and delivering CBT, it's important to make it to adjust the therapy according to the person's cognitive impairments and functional impairments. Consider that they may have memory impairments that limit their ability to kind of do homework or engage in cognitive strategies. So often behavioural strategies, things like amending things in the home, those can be very effective. And the other thing I think is to be aware of self-stigma, that many people with dementia have come to their diagnosis of dementia with specific ideas about what it's like to live with dementia, and you know, what they think about people with dementia, and that can affect their quality of life and their sense of hope and meaning for the future. So addressing some of those, some of that self-stigma can be really important for optimizing their quality of life.
Thanks, Monica. I think that's all we've got time for. We had another question that was very similar, asking about adaptations, which I think you've just answered there. Wonderful insight and discussion we've had today. Thank you again, Monica, for sharing your time and knowledge with us all. I'd also like to thank our audience for your questions, input and interest in the event. If you'd like to watch this session again, we will be screening it on the Bedford Park Plaza Super Screen later in the week, or you can head to the Flinders YouTube page where the content will be available from tomorrow. Thank you once again for joining us. We look forward to seeing you in a fortnight for the next edition of the Meet the Minds series.